Now that I see this is recorded, I will be on exactly point on what I'm going to say.
Mhm. Okay, hello everyone. Before we get started with the presentation, I have a few quick announcements for our MAPS members. MAPS will be hosting a virtual Suture Lab in March, so if you are interested in attending this event, please make sure you fill out the Google form that we sent in your emails, and make sure that you also have paid your semester dues. Your semester dues will help pay or help cover the cost of the suture kits, and you do not have to worry about buying the materials because we will buy them for you, and then you can come and pick them up. The suture kits will include everything you need, like tweezers, sutures, forceps, and a silicone pad. Also, this event will be led by Dr. Martinez, who will be presenting tonight. So if you do want to learn how to suture from Dr. Martinez, then please fill out the Google form we sent in your emails. Next up for announcements, I also want to remind our members about the SNMA Mentorship Cohort Program. This program is a great opportunity for undergraduates because it will place undergraduate students into a GroupMe chat with about 4 to 5 medical students, and this group chat will help provide a platform for discussion and questions about professional schools. And to learn more about this program and other opportunities and resources like upcoming conferences and physician speakers, please take a look at our previous email that we have sent out. We are now going to get started with our event. Tonight, we are super fortunate to have Dr. Martinez here with us. Dr. Martinez is a clinical associate professor of family medicine and is the associate dean for diversity, equity, and inclusion here at the University of Iowa Carver College of Medicine. Dr. Martinez is also super involved here on campus. She is the advisor for the Student National Medical Association, also known as SNMA, and she is also the advisor for LMSA, the Latino Medical Student Association. She is also the advisor for the Mobile Clinic and, of course, MAPS, the Minority Association of Pre-Health Students. I am now going to pass it along over to Dr. Martinez.
Awesome. Thanks again. And thanks so much for joining. I know it's midterm, so we'll hopefully make this speedy but impactful. And then if you guys have questions as I'm going through, seriously feel free to put it in the chat. Let me go ahead and share my screen. Can you guys see this? So we are going to move a little bit deeper into some of the discussions around health equity, bias, racism in medicine, all of that kind of stuff. So that's what we're going to talk about today. So my office exists because health disparities are so real. And unfortunately, from the time that medicine has been created here in the US, we have had real issues with treating folks from all different backgrounds well, which is a real problem. And so we know that a more diverse workforce is important to helping with health inequities. We know that teaching everyone about bias is really important for health inequities. But let's talk a little bit at first about health inequities and some of the stuff that we need to be thinking about. So one of the first things, one of the terrible statistics is that Black women in Iowa are 6 times more likely to die in childbirth. And nationally, it's 3 times more likely. And so we're even double that. And that has to do not just with, the medical conditions that Black women face as they're going to the doctor, but it also has to do significantly with the biases that they receive in their care here. And this is horrific. We know that racial and ethnic minorities receive significantly different amounts of pain medication, both children and adults, when they go for after having a surgery or that sort of thing, totally 100% just based on race. We know that there's differences in how people with heart attacks are treated. So, for example, my dad has heart disease and my dad's a brown man. And if he goes to the emergency room and has symptoms of a heart attack, or anytime he goes to the doctor, I go with him because I know statistically he'll be treated worse by the healthcare system. And not everybody has a doctor and a dean daughter who can advocate for them, right? We know that physicians and healthcare providers are less likely to actually stand closely to a patient if they're a minority, or talk longer with a patient if they're a minority. And minority patients in general are less likely to be believed by the healthcare system, which again, all of this is sort of horrific, right? And the deeper questions too, that, when I'm talking to folks about DEI, why is this happening exactly, right? So other things, so for example, in the 1970s, 2.5% of medical students were Black males. Now it's 2.4%. So it's gone down here since the 70s, now that's a long time ago. We know that 7% of faculty at medical schools are underrepresented minorities. So when you go to medical school, for those, and this is also fairly similar for dental school or PA school or whatever, health professional career you're interested in, the chances of having a minority faculty that is helping to teach you is low, because only 7% of us are underrepresented. So for example, I'm going to be going up for full professor. So there's different ranks of faculty in medical school. And so I'm in the middle rank right now. I'm an associate professor. This next year, I'll be going up to be full professor. So I'll be a full senior faculty member. And I looked at the data today. I think there's like 30,000 white male full professor faculty, and there's 300 full professor Latinas. So I'll be one of 300 in the country who have made it to this level, which is crazy, right? Other things that are really interesting in medicine. So even women who aren't underrepresented, we do not hold many ranks in higher positions, particularly in healthcare. So for example, obstetrics and gynecology, which is 90% female, only 10 to 15% of the chairs of obstetrics and gynecology departments throughout the country are held by women, in a field that only sees women and is 90% women, which is crazy, right? And so why has this happened? Why? And I mean, that is the thing that we always need to talk about. And there's many reasons why. So that's what we're going to talk about today. So briefly, and I think it's always important that we need to talk about our history. And so there has been particularly egregious things that have happened to people with Black identity here in the United States, especially in healthcare. And so this picture of Anarcha, she was an enslaved woman in the 19th century here in the United States. And she was experimented on without any anesthesia by the father of modern day gynecology, making an assumption that women with Black identity have less feeling, and so that they can just experiment with how to do different surgeries and that sort of thing on women who are enslaved, and so, which is sort of horrific, right? And this picture actually of Anarcha is actually in a couple of medical schools, which is sort of terrible, with all of these men sort of looking at her, about to experiment on her. Next, we have Fannie Lou Hamer. She was a civil rights activist here in the 20th century. And we have Serena Williams, who is obviously a world famous tennis icon. So Fannie Lou Hamer ended up getting something called a Mississippi appendectomy, meaning she went in for a procedure, and that was she wasn't, supposed to be having her reproductive organs removed. That was something different. But they, on purpose, also took out her uterus and ovaries so that she was going to be permanently sterilized. And this was a common day practice amongst especially women of color, particularly Black women, but also Native and other women too, which we'll talk about in a second. And then we talk about Serena Williams. So Serena Williams is famous, right? And she's super rich and like amazing. Like, I just can't tell you how much I love her. But she has a known history of like a blood disorder. And after she gave birth to her daughter, she began to have chest pain and shortness of breath. And she told the nurse, "I think I'm having a pulmonary embolism. I think this is what's wrong with me." And guess what they said? No, I don't think so. And they delayed her care. And she got sicker and sicker, and it ended up being a really big problem. So even a woman today who's rich, who's famous, who's well connected, had a bad outcome because of how she was treated by the healthcare system. So this was the picture of the father of modern day gynecology, which we don't even need to say his name, but he is someone who did these surgical experiments. And so here's one of the pictures that exist in medical schools here, and he actually had a statue in New York City that was actually removed recently because people realized of sort of the horrible things that he did historically. So 32 states in the country participated in a really strong eugenics movement. So eugenics is saying that certain people have undesirable genetics and we need to help them to not reproduce anymore because we don't want those people with undesirable genetics reproducing in the United States anymore. And so in 32 states, these eugenics programs targeted Asian women, Hispanic women, Black women, particularly in the South. And by the 1970s, 25 to 50% of Native American women were sterilized in the United States against their will. Obviously, we know too, most of you have probably heard about the Tuskegee syphilis experiment, which was an experiment done particularly on Black men in the rural South. And these men, this was literally the United States government, knew that some of these men might have syphilis. And we actually had a treatment for syphilis, penicillin, which is a very basic antibiotic. We already knew it cured it. But the United States government literally wanted to see, like, what would happen if we just let people have a disease and what happens to them and their families. And so they let this experiment go on until the 1970s without telling them they were being experimented on. And children died because of this experiment, wives died, partners died, and there were tons of complications because of this. And again, this was experimentation by the United States government up until the 70s. We know that minority physicians were not allowed into the major medical societies like the AMA, the Association of Medical, or I'm sorry, the American Medical Association, sorry, AMA, because of racism. And we know that that legacy, it still exists today. It's interesting. So my favorite hotel, this is very bougie of me, but my favorite hotel in Chicago is the Langham, which is a very nice hotel if you ever decide to stay there. And actually right next door to it is the AMA. It's actually the same building. And I always walk by the AMA. And I know now they're trying to do much better and they recently have had some really amazing leadership, but it does have this, and they've actually recently sort of discussed that they've had this extremely racist history. Same thing with the continued, differences in how folks were educated, if they were minorities or not, especially with Black identity in the South, under Jim Crow, separate and equal laws that have gone for many, 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 many years. So why? Why do we continue to see, such inequality here in the United States? And we know, and many of you guys are aware of this, that we do have economic policies, housing policies, social policies, criminal justice policies, all of these policies that have been different and have had racist implications that synergize together that help to create worsening of health disparities. So for example, the wealth gap here in the United States. We know, so for example, one of the major ways that humans in the United States are able to accumulate wealth is one, through education, and is two, from home ownership. And there have been policies here in the United States that have denied or limited access to education for certain underrepresented populations, as well as the ability to buy a home. So for example, right after World War II, a lot of folks were able to tap into something called the GI Bill. Maybe some of you have heard of that before, that allowed for people to get free education or allowed for people to get home ownership. And so in order to sort of create some generational wealth amongst folks. And those same things weren't allowed to happen for those who served in the military that were underrepresented. We know things like redlining has existed. And for those of you who don't know, redlining was something that was very, very common in many, many, many cities throughout the United States. And basically, like banks and city planners would literally take a pen and make red lines on where they wanted minorities to live and where white folks could live. And they weren't in the same spot. And the same resources, infrastructure, and that sort of thing were not provided for those communities in the redlined areas. And you were not allowed to buy a house in an area that was redlined. So for example, you know, in my family, you know, we're from Seattle, originally we're Puerto Ricans from Hawaii, but my family moved to Seattle. And, you know, in the 1960s, I had an uncle who actually was a lawyer and had some wealth, but was a person of color. And they actually had to go through a lot to be able to buy a house in the city of Seattle in a certain area. And they were ultimately allowed, but it took some legal finagling, and it took a white lawyer to intervene. That these policies have been very common, not until it hasn't been that long ago. So why do we talk about redlining? So this is a map on the left of a picture of San Francisco from like the 1930s. And then a picture on the right is the preterm birth rates, where the highest rates of preterm birth exist. And if you notice, do you see any similarities from the map on the left to the map on the right? So we know that racist policies and racist structures impact the health of people today, even things that were just set into motion from like the 1930s. It shows that there are these things that have continued to have these structures that are not good. We know the other thing that is that there is a significant role of implicit or unconscious bias amongst healthcare providers. So there's a lot of, you know, I very rarely although it does exist, come across people in healthcare that I think are sort of explicitly racist. But and most of you, I'm sure most of you have had some training around unconscious bias. So these are the unconscious attitudes that are pervasive, that in snap judgments, even when we're not thinking about it, can make us treat or, you know, behave in a different way, even if we say that's not what our beliefs are. And it's very common. We do implicit bias training for everybody. You know, I have gone through implicit bias, a lot of implicit bias training, because it happens to everybody. And there are tons and tons of studies, hundreds and hundreds of studies that show that across the board, racial and ethnic minorities receive poor care by the healthcare system, even when you control for income status, for education levels, all of those types of things. So for example, as I mentioned before, Black women are 6 times more likely to die in Iowa from childbirth. But if you're a white woman who is poor with a high school education, you're less likely to die in childbirth than a Black woman with a PhD who's a professor at the University of Iowa, statistically. So even when you account for all of those things, these differences still occur. This is some information about, there's now a lot of data that there's a lot of explicit bias, not just implicit bias, particularly towards people with transgender identity, that the discrimination of, you know, a person who has trans identity walking into a physician's office and saying, you know, I need to be treated, them being actually plain out flatly denied care is high, which is kind of horrible. And this is not just for sort of gender confirming you know, procedures or, you know, treatments. This is for like pap smears or basic healthcare. So many of you have seen this before, but in healthcare, what we're trying to do now on the left is equality. So, you know, we know that there have been hundreds of years of disparities and how folks are treated in, you know, by healthcare systems. And but if we say, well, we need to just be equal, we need to treat everybody the same so that it is equal, and that's good. That, you know, here is a picture on the left when everybody is treated equal. You know, not everybody is able to sort of see and enjoy the game that's kind of right in front of them. And so what we're trying to advocate for in healthcare is equity, right? So not everything that we're going to do to help undo all of this horrible stuff that has happened through time, it's not going to be equal, but it's going to be equitable, right? And so the picture on the right shows what equity looks like. And that's what we need to do. So that's why we have MAPS. That's why we have, you know, SHPEP. That's why we have so many of the things that we do. We need to spend extra time, extra care, extra ways to help make life more equitable in healthcare, if that makes sense. We also know that diversity is incredibly important for majority folks when they are training. So here is a picture. There's a number of studies that show if majority folks are around and training with folks that are underrepresented, they will be significantly feel like they're more prepared to work with folks of different backgrounds. Here is sort of some really interesting data. This was a study done, actually, I think it was only 2 years ago, asking medical students, you know, these questions and seeing what they thought. One of them I'll point out here. So for example, Black people have more sensitive, sorry, hold on. Oh yeah, so Black people's skin is thicker than white people's skin. First-year medical students, 40% of first-year medical students believe that. 42% of second-year medical students believe that. So these are asking, and of course, all of this stuff is ridiculous, right? There is no difference. There is, you know, we'll talk a little bit more about biology and that sort of thing, but all of these beliefs, these fundamental beliefs, come from racism. To think that folks from different races, white and Black, have significant differences that exist in these spaces. And we have students, again, going into medical school who believe this stuff or have these ideas. So, you know, what I talk a lot about in at UI Healthcare, as I'm, you know, sort of advocating for health equity and talking about racism in medicine, is that a lot of folks come out with a lot of guilt. That, you know, I think for a long time we said, oh, you're a racist, you know, people start crying, or they're, you know, they just sort of fall apart, because saying somebody is racist is the same as telling somebody, or structure is racist is the same as saying that somebody's a bad person, right? But what we need to get away from, in my opinion, is not recognizing that racism is a good person, bad person thing. It's a person thing. That we have sort of been floating in the waters of racism throughout our country, and that even good people might do racist things, and that we need to be willing to examine that. And that also structurally, like not just the individuals, but our structures have been set up to have racist and unequal outcomes. And those are things that we have to think about and address as well. Does that make sense? So it's less about just like accusing people and them like falling apart, but more thinking about the structures and the recognizing that racism exists in many, many spaces, including with good people. And so one of the things that is, you know, I think a big problem in healthcare today, especially in medical school, is that there is this myth of meritocracy, meaning that, you know, this myth that if you work hard enough, you will sort of get where you deserve, while not understanding the, you know, barriers and the significant disadvantage that some folks have. So for example, applying to medical school, or getting leadership in a medical community, it's like, oh, the smartest and the best person made it, versus some people had significant advantages and privileges they're not even aware of, and some people had disadvantages that make it not just who's worked the hardest to get where they need to go. That is a myth. That's the myth of meritocracy. Okay, so for example, I think 3 of the deans at the Carver College of Medicine had fathers in significantly high positions of leadership in the Carver College of Medicine. Do you think that's comes by chance? No, that if you have legacies, it's easier to know how to navigate the system. So that's why, again, there's this idea, especially, for example, we have so few Black males in healthcare, in particular, that there's this myth, well, some folks deserve it, or some folks, have worked hard, but without understanding the level of barrier that exists for others. Does that make sense? The next thing I do want to talk about today is the fact that race is a social construct. Race is a social construct. Because you are not, at least in medical school, although we're working really, really hard to change this, but it's still not taught very well, that you'll say, oh, well, being Latinx is a risk factor for diabetes, or, having Black identity is a risk factor for, hypertension and that sort of thing. And that there's all of these, sort of genetic differences that create all of these differences in how folks have certain diseases and that sort of thing. And we sort of equate that with race. And in reality, that's actually not true. So how the world has decided race has been more political than anything, and where the lines are drawn. And then some people weren't always considered white, who are now considered white. And, it just like, it's not always been exactly clear, but there's no set of genetics. Like there's not any specific genetic markers that says, okay, this person's Asian, or there's no specific genetic markers that say this person is blank, that race is really much more having to do with this social construct. But the difference is that there is things that are hereditary, right? And so we've used race as an approximation for ancestry, but that's actually not the case. So for example, I identify as Latina, and there might be, and Latinas are mixed with all different types of stuff, there's lots of different things. But if somebody says, oh, there's this one genetic thing that might exist in, a very specific population, let's say in Peru, you would say, oh, being, Latino is a risk factor. When in fact that, being Latino and having a very specific group with specific ancestry is not exactly the same thing. Am I making sense here? Because a lot of times you'll hear people talk about, oh, being Latino is a risk factor and that sort of thing. And most people think it's because it's a genetic component, when most of the time what we're talking about, race isn't the risk factor, racism is the risk factor. So it's, differences in stress levels and disease burden, differences in access to care, differences in treatment, differences in studies that have been performed on different folks. Those are the things. It's racism, it's not race, if that makes sense. So going back to the AMA, they actually, so good things that they've done other than their historical racism, but good things that they've done recently is they actually put out a statement, and I'm going to go ahead and summarize it, but basically saying that we encourage medical schools to characterize race as a social construct rather than inherently biological traits, and support ending the use of race as a proxy for biology. And this is really, really important. And so recognizing that racism is the risk factor, instead of blaming patients like, oh, well, it's because you're this race, you're at high risk, versus understanding it's the racism. So the next thing I like to talk about, the things that we are talking about in healthcare a lot is, privilege and power and privilege. And, why is it hard to talk about race? Why is it hard to talk about racism, even in a medical context? I feel like, it's easy with you guys because, we have probably relatively similar points of view and all that kind of stuff. But, I go into rooms all of the time. And as soon as we start talking about racism in healthcare, you can just see like people start getting red in the face and like it starts like, people's blood pressure are probably going up and all that kind of thing. And systems of privilege and, that it gets to people. It's really hard and people don't want always to talk about it or even deal with it. And for those of you who've read like White Fragility, for example, there's a number of things in there that I think were helpful. So there are a lot of sort of pillars that in our society. So the idea that, that why can't we all be different? So sort of individualism that, I didn't do any of that bad stuff. I'm an individual. Everything's just based on me and how I live life. Versus recognizing that we're all parts of systems that we have to dismantle, and sometimes we experience privilege from those systems, whether intentional or unintentional. But it's all of our job to dismantle it, if that makes sense. There's also the good-bad binary, which I talked about before, that people don't want to talk about race and racism in healthcare because people are like, you're just telling me I'm a bad person, when that's actually not the case. It's not about being good or being bad. So individualism is why can't we all be different? Universalism, well, why can't we all be the same? Like I see all those memes on Facebook and stuff, like, with like skeletons, like, see, we're all the same underneath it all and all that kind of stuff, which is, well, I mean, I won't say it's fine, but it sort of discounts the lived experiences that are different for folks of different backgrounds. And so that's not great. The segregation, so as we talked about before, redlining, intentionally made segregation. There are so many folks who, both of minority identity and majority identity, but more so for folks of majority identity, might go their whole lives without being in significant relationship with people who are different from them, because our country is profoundly segregated. And that's been a big problem. And then an internalized superiority and investment in racial order, which is another thing. Again, so it's hard when you've personally benefited from something to sort of dismantle that system. So when people are used to privilege, equality feels like oppression, right? So when people are used to privilege, if they feel like they've had privileges in their life, equality feels like oppression. So for example, let me think of a different example. Sorry, what's one example in my head? Gay marriage was probably a big example of this, that, many folks were against it because you had the privilege of getting married and people were saying, oh, people want more than just getting married, but it was actually just to be equal. But then people feel oppressed when other people also have that same equality. So anyway, it's a common phenomenon. So one of the things that I often do with physicians and healthcare providers is do this assessment and have them go through these statements and see sort of where are some of the privileges that they might experience in their every single day. Sometimes it's hard for folks to recognize that they have privilege in their life. And so this is one of the ways that we sort of get started in having that kind of conversation. So I might let you read this for a second just to kind of see what exists on this. So I'll give you like 2 minutes.
Yeah, we do. Someone from another area. Yeah, I think it's part of our homeowner association. No, I think it's part of it is there something.
Do you guys have a chance to sort of look over this list?
Not really.
Okay.
No.
So I have a couple of questions. And this is so similar to what I do with a lot of healthcare physicians, but what struck you about this list? What have you seen as having difficulties in these discussions? What are you doing? And basically, I often challenge folks to have an action plan of what they're doing in their life. And so this is kind of an example of some of the questions that we have. This is my very crazy son, but I love him. And his name is Zane, and he's 2. And this was earlier this year when we took a road trip to Sedona. So a 20-hour car trip to escape COVID, but also have a vacation. So, but I would love to hear your thoughts. I kind of covered a lot, and actually relatively quickly. Usually we have a little more discussion during the process. So I would love to hear what your questions, thoughts are. Is this any of this new? Is this different? If not, what do you think? Let me see if I can unshare real quick. Sorry. Ta-da. What are your thoughts?
I thought the checklist that you brought up at the very end, I thought that was very cool. I didn't really, I've never seen anything like that before, and I think that's kind of amazing that you said you do that with a lot of medical professionals. But one of the check boxes on there was that that you could feel like you could walk into an ER and that you would be treated with respect and dignity like that. And I think, unfortunately for my family, since my grandparents are getting a lot older, we do tend to have a lot more visits to hospitals and to healthcare providers. And I think one of the main barriers there would be the language barriers, and I guess not being able to communicate well with providers. I think that's one thing that really limits the care that we have.
Oh my goodness, language is huge. You're totally right. And there's actually a lot of data, both that race concordant care actually improves health outcomes. So there's actually, and this has been in multiple studies. So if even in actually OB outcomes, so I was talking about how horrible it is with Black maternal health in particular. There's data that shows if a Black woman has a Black healthcare provider, the outcomes in pregnancy and in delivery will be better. Same thing actually with language concordant care. So there's data that shows that if your provider speaks the same language as you, the outcomes are better as well. So you're totally right.
Yeah, I was just going to say the same thing that Aaron said with the language barrier. I know from my personal experience, that was really tough just for my parents and then for everybody else in my family from a young age. I know that some children may have to be like their parents, like little translator, like a little helper almost. And that's not, and from my own experience doing that, it was horrible. Like, obviously, I don't know medical terms, even when I was like super young. And so putting in that type of responsibility and pressure on someone who should not have that type of responsibility is a big problem, I think, in a big loophole in like the system for the language barrier in healthcare. And I think kind of like what Aaron was saying, overall, I think for medical students, if they're exposed to more languages and have that type of like mindset of, okay, this patient may have a preferred language that may not be English, having that in the back of your mind could be a great way great mindset to have going into every single room, in my opinion. So.
Yeah, no, I think you're totally right. And yeah, and I feel I didn't have that. I was not my parents' interpreter growing up. But I feel for so many of my friends and so many of you likely who had to do some of that really hard, heavy lifting, especially in the medical setting where there are so many terms and so many concepts. I still, I grew up and, like I had family members who, would speak Spanish, but I still like never heard and didn't even know the term for many of I still don't know a lot of the words today, like I don't know what's the word for uterus. I'm not entirely sure, like those are hard concepts, and to try to negotiate, especially is hard. It's a lot. So you're right. Part of doing good care and culturally competent care, because unfortunately we often, won't always have in-person interpretation for every language all the time, but we should for at least all of the languages that we have the highest proportion of folks in. But then we also do have like Skype, like Zoom style language interpretation now that every single physician and medical student has access to at UI Healthcare. Again, it's not ideal, but it's something that has to be used and should be used. And there's actually data that shows that, I think it was something like, oh, don't quote me, but it's a decently high percentage of resident physicians, so physicians still in training, had seen their attending physician use a child under 12 as an interpreter in a medical situation, which is completely unacceptable.
Going off of that, I just have two things to mention. So one, especially in telelocal clinic, we've ran into different instances where maybe the patient isn't able to access like a video call, so they're going to have to do a phone call, but it's so much harder for the interpreters to, understand them without the body language and without actually seeing them on the screen. So that's kind of a big issue that is hard to deal with because we don't always have the available translators, and it's just hard to get around that. So we end up just doing a phone call because we still want to provide care, but it's just difficult for both the patient and the translator.
Yeah.
And then just the other thing I was going to mention is that like all the information you presented was so powerful and so blatantly obvious that it's an issue. And I feel like not everyone has access to this information. And like, especially as undergrads, I feel like this is something that everyone should be hearing. And sometimes, unless you go out of your way to go to events like this, you're not getting exposed to this information, which is super important.
Yes, I agree with you. And, fortunately, this is not that it's the best. Fortunately, there's more and more of this information that we're having to, at least even for our accreditation, which I applaud, particularly medicine, dentistry, and some of the other specialties still need to catch up to this. We will not be accredited now as a medical school if we don't share certain things around this kind of stuff, which I think is really, really, really important. But you're right. I think it should even be earlier. And I think that, I know that there's talks, and I actually would encourage Iowa, although it might be a pain in the butt for all of you all as students, that people have to take some sort of, health equity course or something like that before applying to medical school.
My question that I had kind of goes along the lines of that. So how often do you think like these type of like presentations that you were given, like how often do they are shown to like undergrad students that are like pre-med and to like med students, like exposing them to the idea that yes, there is like inequality in medicine? Like how often do you think it's like not sufficient enough, or do you think the message is there?
Yeah, I don't think it's sufficient enough. But, there are a number of touch points. And right now we've done a big overhaul over the past year. I don't know if you know, Dr. Shibley Rahal is an amazing dean in the College of Medicine and has really taken this to heart and is one of the dean of our curriculum. And so both in the preclinical curriculum, so like the actual like book time, and also the clinical curriculum when you're on the wards, that there has to be principles around health inequities and health equity and that sort of thing put into what everybody is learning. So and our medical students are the ones who also helped push for that. The message was loud and clear, which I think is awesome. I think the other space though is that we can do it with students. I don't know about undergrad students. I'm not involved at all in undergrad medical curriculum or anything like that, so I don't know, but I do think it might be helpful, especially before students go into medicine, to have better understanding of this. And then, but the other piece is that if you learn about all of this stuff, and then your faculty, when you get to the wards, who are teaching you how to treat patients, don't know any of this stuff or haven't sort of done any sort of health equity learning themselves, or implicit bias or that sort of thing, then people start mimicking and seeing the bad habits, and things continue. So part of our efforts, actually, we do in my office, I actually have Dr. Mosier, who identifies as a 50-something white male, straight, who does actually a lot of our trainings for our faculty. And he's amazing. But one of the reasons why I like that he has majority identity is because I do think folks also listen to him, which is good and bad. But that's one of the reasons why he's one of our main faculty trainers.
Yes, we have a comment in the chat. I apologize if I don't pronounce your name right. Mimi Roberts says that she thinks that, or he or she thinks the checkbox thing is a perfect way to ease into the conversation of racism.
Yeah, no, I think yeah, I agree, totally agree. Other thoughts or?
I just wanted to share that when I saw those stats about the trans people that get like blatantly denied their healthcare, like as someone that's non-binary, that's very scary to see that you could be like, it could be life or death and you could be denied healthcare simply because you are not cis. It's just scary. That's something that I picked up.
Oh goodness, no, yeah, no, fair enough, totally, and thank you for sharing. It is, and so but my strong hope is, that things will change in the future, and that's why we need folks who care about this kind of thing, because it has to change. And I actually hope legally things change too, right? So that there are enough repercussions for folks who discriminate. One of the things I love is, and you guys might know Dr. Katie Mborick and Dr. Nicole Knisley. So they started the LGBTQ clinic here at the University of Iowa. And so they see patients who, especially tons of people who have non-binary and other trans identities and gender non-conforming identities. And it's a very safe and excellent place to get care. But one of their goals when they do training, so they do tons and tons of trainings around the state, is that we hope we train ourselves out of this clinic and out of our job. That so many people provide so much good care for people with non-binary or trans or whatever identities, LGBTQ plus identities, that this clinic isn't needed anymore. And that's my hope too.
I just had a quick question. So like, I feel like with health equity and stuff like that, in like my experience, I feel like it's something a person has to be like interested in enough to like go after it and kind of like learn more about it. So like, what could we do like now as like pre-health students and stuff like that to kind of like integrate it, or like, I don't know, ask for change and in like the mainstream education kind of thing, because otherwise I feel like if people don't really know about it or notice it, they wouldn't like seek out knowledge about it.
Oh, that's a good question. Good question. Love it. I'm not sure. Have you any of you guys gotten any other than MAPS or sort of seeking it out? Have any in your different curriculums? Because I know there's lots of different majors. Have any of you had any health equity discussions?
Yes, for human physiology, I believe there is a cultural competency class. I am taking that right now, and the whole class is based on mainly just discussion. We watch lecture and then we have discussion in those icon discussions, but we mainly talk about health disparities and cultural competency. The whole class is all based on cultural competency. So that's one class. I know mainly for human physiology. I think it's an elective class.
Got it. I mean, I think one way, although it's hard, I think as an undergrad to push for this, I think if medical schools require it, everybody will do it. Or other health professional schools. I'm sure, as soon as it's a requirement, and I think right now Iowa is actually tossing that around, that people have to have some, and we would also provide free resources. Like there's a 1 credit class from some place that is free that people can take if they, even if it's something that isn't that hard to obtain some of that knowledge. I do think that's one strategy, but I don't know. I would love to hear your guys' thoughts. Is there ways to sort of say, as undergrads on the pre-med or pre-health track? Or do there need to be more just everyday these everyday types of discussions in some of the STEM curriculum? Or I'm not sure, but I think it's a good question. Mimi also said, yeah, I think we should require it. I agree. I think as soon as you require it, everybody will do it. For good or for bad, but at least it's something.
I think actually a nice thing that one of my professors does is for my evolution class, my professor talks about a lot of the issues in like science and like the kind of ramifications they've had in like society, and like brings that to the forefront and kind of like explains where it's coming from and like where we can actually like do better and learn for it. And so I think that's actually a really nice thing that like you don't really see in a lot of these courses, which is kind of very appreciated.
No, I think it's awesome. And it's hard because I mean, I do think, not that even folks like me, like I still make mistakes. I still have biases. I still have a lot that I, on an everyday, have to really work to make sure, am I doing things the right way? You know, and I live this stuff. This is literally my job. And then there are lots of folks like all of you who are here, likely because you care too a whole lot. And then there's some folks who don't or really don't, or at least don't even understand. And how do we create those spaces and buy-in for those folks? Because it's literally, sort of as Nikki mentioned, it's literally life and death for some folks. Well, honestly, talking with you guys brings me super joy because it gives me hope about our future in healthcare. I know you guys care. You need to go into healthcare. You need to be doctors and dentists and all of those things. We need you, we need you, we need you. And I'm always happy to help. Our team is happy to help. Yeah, and I really hope next year or in the very near future, we can all hang out together.
Can I make a plug real quick?
Yes.
I'm gonna plug Mobile Clinic right here. Yeah, so if you want to get involved, we reach out to underrepresented communities and we provide free healthcare. So Mobile Clinic is a great way that both the Carver College of Medicine and undergrads can get involved in trying to reach out to underrepresented communities to help them get free medical care. So there's my plug, Mobile Clinic.
I'll take the plug. Excellent, excellent plug. I fully support that. And actually, so I'm the co-medical director for the Mobile Clinic, and we will be hopefully soon, you know, in the next couple of months, doing vaccine clinics to some of the most vulnerable local communities, which would be super fun for folks to volunteer at.
Okay, thank you so much, Dr. Martinez, for leading this presentation and discussion today. I really thought that your presentation was amazing. You really did a great job of providing students with examples so that they kind of understand the concepts and terminology. So thank you for that. Just a quick reminder for our members to look at that Google form for our suture clinic or virtual suture clinic, or wait, virtual suture lab, and take a look at our previous emails with all the other opportunities and resources. Thank you so much, everybody, and thank you, Dr. Martinez. Have a great night.
Thank you.